بسم الله الرحمن الرحيم. هنتكلم النهارده about a very important subject which you meet through all your career. We will talk about the infection control, infection prevention and control. Okay. First, we have to collect some knowledge about hospital-acquired infection. By the end of this session, you have to identify the basic concepts of infection control, to explain how infection control can decrease the incidence of nosocomial healthcare associated infections and antimicrobial resistance. What's infection control? Infection control is the art concerned with preventing nosocomial or healthcare associated infection. It is a practical subdiscipline that is supported by an academic background of microbiology and epidemiology, which works very closely with the microbiology department. It is an essential, though often under-recognized and under-supported, part of the infrastructure of health care. We have to know some definitions to start with. Infection control program, the process or the discipline by which healthcare facilities develop and implement specific policies and procedures to prevent the spread of infections among healthcare staff and patients. Healthcare associated infections or nosocomial infections, an infection contracted by a patient or staff member while in a hospital or healthcare facility for not less than 48 hours and not present or incubating on admission. This infection, the process of microbial inactivation that eliminates virtually all recognized pathogenic microorganisms, but not necessarily all microbial forms, for example, spores. Sterilization, the use of physical or chemical procedures to destroy all microbial life, including large number of highly resistant bacterial endospores. Procedures include steam sterilization and heat sterilization. Why infection control is one of the most important aspects of environmental safety. Hospital-acquired infections are a common problem. Hospital-acquired infections contribute to antimicrobial resistance through overuse of antimicrobials that helps development, poor infection control practices that helps spread. Why it is important? Patient protection against nosocomial infections, medical staff protection, and environmental protection. Why we should fight hospital-acquired infections? They are considered the main cause of death, considered the indirect cause of death, impair the quality of life of the patients, causes expensive use of healthcare resources. Healthcare associated infections, nosocomial infections. By the end of the session, we have to enumerate root causes of nosocomial infections, to define infection, to define carrier, to define colonization and contamination, to illustrate types of nosocomial infections, to enumerate risk factors of nosocomial infections, to illustrate preventive measures of nosocomial infections. A Norwich surgeon in the end of the 19th century said this sentence: "I have unwillingly and almost tremblingly proceeded to operate in the hospital. I came to the conclusion that pyemia, if it does not find its birthplace, it does find its natural home in hospitals, and although the hospital may not be the mother of the pyemia, it is its nurse." Root causes of nosocomial infections. Normally, people seeking healthcare services may be more susceptible to infections. Also, people seeking treatment may have infections that can be transmitted to others. Patients undergoing invasive procedures may be at increased risk of infection if basic infection control practices are not observed. Healthcare providers may transmit infectious agents directly or indirectly to clients and to themselves unless basic infection control practices are observed. Other general factors that contribute to potential cross-transmission may include overcrowding during periods of high admission with limited physical space for carrying out appropriate infection control practices. Also, staff shortage. Poor infrastructures to support infection control practices may help spread of infection in the hospitals. Lack of training in basic infection control, inadequate facilities and techniques for hand hygiene, lack of isolation precautions and procedures, inadequate sterilization and disinfection practices, and inadequate cleaning of hospitals. Also, use of advanced and complex treatments without adequate training and supporting infrastructure that includes invasive devices and procedures, complex surgical procedures, interventional obstetric practices, intravenous catheters, fluids and medications, urinary catheters, and mechanical ventilators. We have to know types of infection: community acquired or hospital acquired. Community acquired infections, the entry and multiplication of an infectious agent derived from the community in the tissues of the host. Hospital acquired infection or nosocomial infections, an infectious disease acquired in a healthcare facility and was not present or incubating at the time of admission. What's infection? The organism has entered a site, had colonized, and caused pathological and immunological reactions with or without clinical signs. What is a carrier? A healthy individual living chronically with organisms. Colonization, survival of organisms without primary or secondary immunological defense. Contamination, normal flora and organisms present without direct consequences. Nosocomial infections have a Latin origin, nosocomium, means hospital or related to hospital or health care facility. The Greek origin, noso means disease and comium means take care. English nosocomial infection or hospital acquired infection. Recently emphasized on healthcare associated infections, iatrogenic events. So, nosocomial infections could be identified as nosocomial infection, an infectious disease acquired in a healthcare facility and was not present or incubating at the time of admission, and it should be within 48 hours after admission. General definition of nosocomial infection: infection that occurred after 48 hours of admission or more than the incubation period of a specific disease. Population at risk: patients, healthcare workers, and others. Others include visitors, the surrounding community of the hospital, housekeeping. We may consider housekeeping workers as members of the hospital. Risk factors. There are some risk factors which are considered as individual patient risk factors. They are concerned with the general conditions and case of the patient. Some are intrinsic risk factors, that means endogenous, like malnutrition, hypoalbuminuria, albuminuria, extremes of age, immunocompromised or cancer patients, diabetes plus or minus obesity, loss of skin or mucosal integrity, coexistent illness, trauma, long preoperative stay. Extrinsic risk factors: exogenous, high risk medical devices, shaving surgical site, operating procedures, length of the surgery, surgical technique, foreign body, wound class, and aseptic technique, environment maintenance. Determinants of an employee's risk: the probability of occupational exposure to the potentially infected material, the prevalence of the target of an infection, prevalence of the target infection in the patient population surveyed. Epidemiology of nosocomial infection. Most common site of nosocomial infections: surgical incisions, urinary tract, catheter related, lower respiratory tract, bloodstream, catheter related. Common microorganisms which may cause nosocomial infections: aerobic gram-positive cocci, Staphylococcus aureus, the most famous MRSA, Sicilian-resistant Staph aureus, Enterococci, again the vancomycin-resistant, aerobic gram-negative bacilli, Escherichia coli, Pseudomonas aeruginosa, Enterobacter species, and Klebsiella pneumonia. Epidemiology of nosocomial infection, nosocomial transmission of community-acquired multi-drug resistant organisms like TB, Salmonella species, Shigella species. Those are normally and Vibrio cholera. These diseases are found in the community but may be transmitted to the patient in the hospitals or from the hospital to other patients. What is the sources of microorganisms? Endogenous from the patient, exogenous from healthcare workers, hospital to patient, environmental, again hospital to patient. Starting with the first and the commonest nosocomial infection, surgical site infection. It is usually classified as superficial incision surgical site infection, and it occurs within 30 days. It involves skin or subcutaneous tissue. Deep incision surgical site infection. Infection occurs within 30 days after the operation or 1 year with implant. It involves deep soft tissue. Organ or space surgical site infection. Infection occurs 30 days after the operation or 1 year with implant. Infection involves organs, spaces, component. This diagram shows the superficial incisional infection will be in the skin and subcutaneous tissue. Deep incisional will involve deep soft tissue, fascia and muscles, and organ or space surgical site infection will take an organ or a space like the abdominal space. Okay. Manifestations and diagnosis. You have to notice the patient for purulent drainage, as for the incision, superficial surgical site infection. Purulent discharge, pus comes from the surgical site, with or without laboratory confirmation. Organisms isolated, at least one of pain or tenderness, swelling, redness or heat and incision, opened by a surgeon. That means clinical diagnosis. All the mentioned points could be used for the clinical diagnosis. Deep incision surgical site infection. We may notice purulent discharge from deep incision, not from the organ or space. Spontaneous open of the wound, and the patient has at least one of fever, pain, tenderness. Maybe an abscess will be formed. Surgeon confirmation will confirm the diagnosis. As for the organ or space, peritoneal space, purulent drainage, organisms isolated, an abscess or other evidence of infection, diagnosed by surgeon or attending physician. Prevention. Preoperative measures concerning patient, OR team, OR environment. Preoperative measures for the personnel, the team, wear operative room attire, surgical scrub, barrier devices, aseptic techniques. Preoperative measures for patient, very short hospitalization, required investigations before admission, improve the general condition, treat infections, the basic patient preparation, shower, hair trimming, administration of prophylactic antibiotics, proper patient preparation, draping on table. Surgical site infection, operating room environment, a good circulation and a good design, high quality OR management, a policy of cleaning the OR, availability of a waste disposal system. The second most important hospital-acquired infection is urinary tract infections. Classifications and manifestations. Asymptomatic bacteriuria, patient has no symptoms, no fever, no dysuria or frequency. Symptomatic urinary tract infection with or without history of catheterization, patient has one of the following symptoms: fever more than 38 centigrade degree, urgency, dysuria or suprapubic pain. For the diagnosis, asymptomatic bacteriuria, patient has history of urinary catheter 7 days ago and a positive urine culture of more than 10 to the power 5 microorganisms per milli. Or he has 2 positive urine cultures of more than 100,000 microorganisms per milli of the same organism. Symptomatic urinary tract infection with or without history of catheterization. Patient has positive urine culture with no more than 2 isolated microorganisms, or he has positive urine culture more than 1,000 microorganisms per milli and positive leukocyturia of more than 10,000 leukocytes per milli. To secure reducing UTI, the following recommendations should be followed. Personnel should be trained. Catheter use should be avoided whenever possible. Hand washing is essential. Catheter insertion is considered as a minor operation. Closed sterile drainage. Irrigation, specimen collection, urinary flow, meatal care, catheter change interval, spatial separation of catheterized patients, bacteriologic monitoring. Nowadays, the respiratory tract infection may represent a major problem, especially for the people with COVID-19. It is important to know how to stop the spread of respiratory tract infections, especially with people using ventilators. Proper cleaning and sterilization or disinfection of reusable devices, use efficient filters, sterile water should be used for humidifiers. Prevent person-to-person transmission, restrict to standard precautions, care of tracheostomy, proper suctioning of respiratory secretion. Intravascular catheter-related infections. Classification. Local catheter colonization, phlebitis, exit site infection within 2 centimeters around the cannula. Bloodstream infections, bacteremia, could be primarily from the inserted cannula, secondary in patient with IVC. As for the manifestations, we have local manifestations in duration and or erythema along the subcutaneous tract of the catheter, signs of inflammation, exudation, purulent fluid at the catheter site exit, biculture of catheter tip, bloodstream infection, bacteremia, fever more than 38 degrees Celsius, chills, hypotension, one positive blood culture from peripheral blood culture. Prevention. Peripheral catheter, minimize patient exposure to peripheral catheterization that could be through insertion only if necessary, early removal if not used. Maximum duration of an adult is 96 hours. Daily inspection of the insertion site and immediate removal if infection is suspected. Hand disinfection before insertion, hand disinfection before insertion. Skin and hand. A major line is the central venous catheter. A written protocol for using central venous catheter should be present in the intensive care units. The indications for insertion and the duration of the central venous catheter should be limited. Continuous education of healthcare workers and how to care about this central venous catheter. Continuous and the protocol should contain information about precautions for insertion, surgical conditions, sterile mask, cap, gowns, and gloves, large sterile drafts, skin disinfection, limit the use of the venous line, insertion site, subclavian, if more than 5 to 7 days, jugular, femoral, tunneling of central venous catheter for jugular or femoral site. Types of catheter: polyurethane, silicone, better than Teflon or PVC, monolumen or multilumen, coated catheters with silver chlorhexidine, sulfadiazine possible, with heparin, less thrombose. Used in aseptic conditions, daily clinical surveillance, no scheduled systemic replacement, CVC dressing, date of placement, occlusion, dressing. Every 7 days if using transparent dressing, 2 days if using gauze. Replacement of administration sets at 72 hours. Replacement of the lines. The CDC now recommends leaving CVC catheters in as long as necessary, or optimum 72 hours, except if blood transfusion or lipid perfusion change per day. Gastrointestinal infection. Classification: gastroenteritis, food poisoning, acute onset of diarrhea with or without vomiting, hepatitis, and jaundice. Manifestations and diagnosis: gastroenteritis or food poisoning, 2 of the following: nausea and vomiting, abdominal pain, headache, any laboratory evidence of enteric pathogens. Gastrointestinal infection continuously is hepatitis. 2 of the following: fever, anorexia, nausea, vomiting, abdominal pain, jaundice or history of transfusion 3 months ago. Laboratory confirmation: positive laboratory tests for hepatitis viruses, abnormal liver function tests. Food and water precautions. Contamination of food and water supply frequently occurs in hospitals. Inadequate cooking may lead to overgrowth of pathogenic bacteria. Food handlers may contract an infectious disease. Policies and procedures to prevent food and water contamination are necessary. Systemic infections. That includes viral etiology like mumps, influenza. Many organs are involved, diagnosed only clinically. Example: mumps, rubella, and varicella. Thank you.